Hello, I'm Bobby Jean Schweitzer, and I will be presenting on Gastrointestinal and Hepatic Systems Part 2. This lecture module will consist of end-stage liver disease, coagulopathy, and perioperative care. And we're going to start with end-stage liver disease. Let's start with a question. You are providing anesthesia for a patient for a transjugular intrahepatic portosystemic shunt, better known as TIPS, who has cirrhosis. Which of the following tests are used in calculating a model for end-stage liver disease or MELD score? A, the creatinine level, B, fibrinogen, C, prothrombin time, D, serum glutamic oxaloacetic transaminase, or SGOT. And the answer is creatinine. Answer A is correct because creatinine is a component of the MELD scoring system. Answer B is incorrect because fibrinogen is not a component of the MELD scoring system. Answer C is incorrect. It's a little bit of a tricky question because the prothrombin time is a component of the Charles-Pugh, but the INR is a component of the MELD. Answer D is incorrect because serum glutamic oxaloacetic acetic transaminase is not a component of the MELD scoring system. And in fact, SGOT is an old terminology that is not used anymore. So let's talk a little bit about the circulatory system in end-stage liver disease. With end-stage liver disease, one typically has a hyperdynamic circulation. That means there's normal to low systemic blood pressure, but an increased cardiac output and decreased systemic vascular resistance. This is due to vasodilation and abnormal shunting. There's also portal hypertension, and this is due to a high resistance to blood flow through the liver because of scarring and cirrhosis. There's a presence of esophageal and gastrointestinal varices, splenomegaly, and ascites, and a propensity for bleeding. The portal system is an integral part of the liver pathophysiology. Portal hypertension occurs when the physiologic reserve of the liver is depleted. There's portosystemic shunting. It's caused from cirrhosis-induced portal hypertension, and this circumvents hepatic filtering. It allows drugs, nitrogenous wastes, and toxins to enter the circulation directly without being filtered through the liver, and it contributes to encephalopathy. Pulmonary complications are common in patients with end-stage liver disease. And these are often very serious and life-threatening complications. Hepatopulmonary syndrome is due to intrapulmonary arteriovenous communications and shunting. There's also atelectasis and restrictive lung disease secondary to ascites, and pleural effusions secondary to volume overload and hypoalbuminemia. Portopulmonary hypertension is one of the end-stage complications of liver disease and often results in death. This is due to an increase in pulmonary vascular pressures. It occurs in less than 5% of patients. It's associated with metabolic acidosis, hypoxemia, hypercarbia, and worsened pulmonary hypertension from the hypercarbia and the hypoxemia and the acidosis. So it's kind of a vicious cycle. There's a risk of right heart failure in patients who have portopulmonary hypertension. Encephalopathy is also a common finding in patients with advanced liver disease. And this can range from an altered mental status all the way to a coma. Patients can have tremors, seizures. This is due to an accumulation of chemicals, especially ammonia. There's altered cerebral metabolism and disruption of the blood-brain barrier. And so the treatment of encephalopathy includes reducing the ammonia load. This can be done by administering oral neomycin. This reduces the urease-producing bacteria in the gut, and administering lactulose, which can reduce ammonia absorption by binding ammonia in the gut, and then excreting it through the bowel. Flumazenil may reverse encephalopathy, It seems to, the effects on the gamma aminobutyric acid or GABA receptors may be the mechanism, or is the likely mechanism of the reversal. One should treat the underlying infection or condition that may have precipitated the encephalopathy, and be sure to rule out other causes of altered mental status, such as intracranial bleeding. Remember, these patients are prone to bleeding because they have prolonged prothrombin times, decreased coagulation factors, and thrombocytopenia. There also may be masses. Many of these patients have HIV, hepatitis C, hepatocellular carcinoma, and so they are prone to neoplasms as well as intracranial infections and hypoglycemia from the liver's inability to manage glucose and having the decrease in glycogen stores. Ascites occurs in about 50% of all patients with cirrhosis. It's associated with significant morbidity. It's an indication of end-stage diseases. You don't typically get cirrhosis until one has lost most of the capacity of the liver. It's secondary to hypoalbuminemia, as well as sodium retention, as well as portal hypertension. Ascites causes atelectasis. It causes restrictive pulmonary disease. It can compress the IVC and the right atrium and decrease preload, and therefore decrease cardiac output and blood pressure. Spontaneous bacterial peritonitis can occur in the setting of ascites, and often is the tipping point for worsening of encephalopathy or decompensation in patients, so it's always a consideration in patients with ascites. The treatment consists of diuretics, fluid and sodium restriction, and paracentesis, or withdrawing of ascites directly through the abdomen. It is important that one doesn't take off too much fluid and one avoids hypotension when performing paracentesis. Hepatorenal syndrome is sort of a feared complication and is often associated with very severe end-stage disease and poor prognoses. This is renal insufficiency in patients with advanced liver disease in the absence of any obvious direct cause of renal failure. It's associated with intense renal vasoconstriction and is secondary to decreased effective arterial circulating blood volume. There's two types. Type 1 is hepatorenal syndrome is rapidly progressive. It's pre-renal failure. It has a very poor prognosis, and usually the only effective and the best treatment is emergency liver transplantation. The presence of this condition usually moves the patient up to the top of the transplant list. Type 2 hepatorenal syndrome is generally milder, has a more gradual onset, more limited degree of renal dysfunction. It can be treated sometimes with octreotide, glucagon, or midodrine to affect a renal vasodilation. Let's talk about coagulopathy, which is a common complication of liver disease. Let's start with a question. You are reviewing labs on your TIPS patient and see that she has a prolonged prothrombin time, or PT. You are studying for your boards and you decide to review the coagulation cascade. Which of the following is not synthesized by the liver? A, factor 12, B, fibrinogen, C, von Willebrand's factor, D, factor 2, E, factor 9. So all of these are synthesized by the livers except for which one? And it's C, von Willebrand's factor is not synthesized by the liver because it's synthesized in the endothelial cells in the vascular lining. A is incorrect because factor 12 is synthesized by the liver, fibrinogen is synthesized by the liver, and factor 2 and factor 9 are both synthesized in the liver. So coagulopathy and liver failure is the inability to produce adequate coagulation. One of the best monitors is monitoring the prothrombin time, or the PT, but also using the partial thromboplastin time, or PTT, and fibrinogen levels. The PT typically stays within normal range until the prothrombin complex is at least 70% below the lower limit of normal. The PT is not a very sensitive marker, so one has to have 70% decrease before you'll ever start to see any prolongation of your PT. But the converse is true, that once one does see a prolonged PT, it indicates that one is below the 70% level. Therapeutic use of vitamin K can correct a prothrombin, a prolonged PT, because malnutrition is a common associated condition with liver disease. It will also treat a reverse warfarin-induced prolongation of the PT. It's correctable with both enteral as well as parenteral vitamin K, so you can give it orally or you can give it subcutaneously. Malabsorption is, to treat the malabsorption, though, of vitamin K, you would need to give parenteral or very large doses of oral, or larger doses of oral vitamin K. In liver dysfunction, true hepatitis or cirrhosis, then vitamin K is ineffective. So the coagulopathy, we mentioned about different diagnostic parameters. So that includes the prothrombin and INR that we've talked about briefly, but also platelet counts and thromboelastography, or TEG. The treatment of coagulopathy is fresh frozen plasma, platelets, cryoprecipitate, aminocaproic acid, or Amicar, and activated recombinant factor 7. This is a pictorial of a TEG, and you can see that the different components of it assess coagulation versus fibrinolysis, and can be used to assess both clotting time as well as clot strength and lysis time. TEG is typically used only under sort of special circumstances. It is a little complicated to evaluate, but they do like to ask questions on the boards. So you can see here that, the left-hand side is the coagulation, the right is the fibrinolysis, and the height of the graph is the platelet. So a low MA level indicates that platelet transfusions are indicated. The first part of the TEG, the line and the length of that, is the enzymatic. The second is fibrinogen, and the last is thrombolysins. And so if you have a prolonged R component and the patient is not on heparin, then FFP is indicated. If you have a prolonged K component, then that is generally due to a low fibrinogen level, and this affects clot kinetics, and replacement would be with fibrinogen. And then the high LY30 component means that antifibrinolytics are indicated because there's an increase in fibrinolysis or clot breakdown. So TEG assesses both the formation and stability of clots and then the lysis of clots. So let's talk a bit about perioperative care of the patient. And we'll start with a question again. Which of the following are contraindicated in your patient with advanced cirrhosis? A, central line placement. B, central neuraxial anesthesia. C, an arterial line. Or D, transesophageal echocardiography. And the answer is central neuraxial anesthesia. So answer B is correct because the patient has a prolonged prothrombin time, which will increase the risk of bleeding and spinal epidural hematoma. Answer A is incorrect because evidence shows that central lines can be placed safely in patients with coagulopathies. There is an increased risk, but it's felt that the benefits often outweigh the risk. Answer C is incorrect because of the same reason as answer A. There is an increased risk of bleeding and hematoma, but if it's determined that the benefits of intraarterial or central line monitoring or placement outweighs the small risk of bleeding, then they should be undertaken. Answer D is incorrect because evidence shows that transesophageal echocardiography probes can be safely placed in patients with both coagulopathies and esophageal varices. So again, one weighs the benefits against the risks. So anesthetic management has an impact on hepatic blood flow. General anesthesia typically decreases hepatic blood flow by about 20 to 30%, and this is mainly due to decreased hepatic perfusion pressure and is directly related to arterial blood pressures. Central neuraxial anesthesia, typically a T5 level or higher, decreases hepatic blood flow by about the same amount, 20 to 30%. Lower levels would decrease the perfusion less. And again, this is usually directly related to the arterial blood pressure. The lower levels below T10 generally have minimal effect on both blood pressure as well as hepatic blood flow. Peripheral nerve blocks in monitor anesthesia care typically have minimal to no effects. So intraoperative monitoring, if major surgery is going to be undertaken in a patient who has significant liver disease, an arterial line is almost always indicated. A central line may be useful, and again, the risk of a central line typically is quite low, even in patients with significant coagulopathies. Though if the patient, it may be useful, particularly if it's an anticipated difficult central line placement, or the patient has severe coagulopathies, to correct these ahead of placement. External jugular vein access appears to be safer in patients who have coagulopathies as opposed to internal jugular or subclavian line placement. Transesophageal echocardiography can be very, very useful both in these patients as well as in patients with cardiac conditions. It is patients who do have varices are at risk for bleeding with TE exertion, particularly if it's difficult. But generally, this can be performed safely with a low risk of complications. So IV anesthetics for induction have minimal effect on hepatic blood flow as long as blood pressure is maintained. I can't emphasize enough that if your arterial blood pressure drops, your hepatic perfusion will drop. So maintaining blood pressure is probably the overarching most important aspect of perioperative anesthesia management. Rapid sequence induction may be indicated in patients with ascites. It can increase intergastric pressures and increase the risk of regurgitation and aspiration. Hypotension is common due to low systemic vascular resistance and relative hypovolemia in these patients, and that is only aggravated with the vasodilatory cardiac depressant effects of anesthesia. Volatile anesthetics exacerbate hypotension, but are not contraindicated as long as blood pressure is maintained. There is, frankly, no optimal anesthetic technique that has been identified. The technique that has the least perturbations on hemodynamics and volume will be the safest anesthetic to administer. So postoperative jaundice, we're going to talk briefly about. The differential of that is obstruction, liver injury due to viral insults, probably most commonly associated with blood transfusions, toxins such as excess acetaminophen, ischemia, which is a term shock liver, which is secondary to generally hemorrhage, hypovolemia, decreased cardiac output, or hypoxia, and hemolysis. Thank you very much for your time.